Welcome, everyone, and thank you for joining our presentation on the opioid-exposed newborn. I'm Dr. Mike DeVoe, a neonatologist, and I am serving as the state project lead for this quality improvement effort. This discussion is sponsored by Tennessee Initiative for Perinatal Quality Care, or TIPQC, as part of a 3-year quality improvement effort. Almost all of you are acutely aware of the problem and care of the opioid-exposed newborns. Today, we'll attempt to give a thorough review of the subject by covering 3 subject areas. Number 1, we'll be focusing on the background and incidence of opioid-exposed newborns. Number 2, we'll be discussing potentially better practices for all aspects of perinatal care for opioid-exposed newborns, including prenatal, perinatal, and discharge care. Third, we're going to be discussing potential long-term care issues for both the mother and the infant, including hepatitis C, appropriate follow-up services, etc. I know all of you involved in caring for these complex maternal-infant dyads, and we're using that term frequently now to refer to the mother and infant together as a unit, are challenged not only by the complex medical care of these patients, but particularly during the current pandemic, many of us are doing this in the face of diverted resources. I'm sure all of you have dealt with staffing issues, pressure to discharge, etc. And although, we're dealing with these pressures and outside influences, I expect most of you feel that we have the opportunity to improve the care we're providing to these infants. And if you do believe that, raise your hand. And I know I certainly do believe that we have a long way to go, but we've come a long way in the last 2 to 3 years this project's been underway. How do we accomplish this and take this project onward and continue to show improvement? Now we're going to discuss the facts and progression of the problem, or how did we get where we are today. Over a 14-year time period, there was an 8-fold increase in opioid-exposed newborns, faster in the Medicaid population than the general population. The costs to the healthcare system are significant, and in 2014 alone, it approached $462 million. It's been well established in multiple quality studies that value, which is a cost-benefit analysis, can be increased and outcomes improved by decreasing the variability in care. Shown on the current slide is a historical timeline of the opioid crisis. As you can see, this is not a new problem. Morphine was first described almost 200 years ago, and over the last 200 years, it's morphed into a social and healthcare cost crisis. A matter of fact, it was not declared an epidemic until 2012. Definitions are important. We use them all the time. If you've looked at the literature, I know that you've seen terms thrown around left and right, and we're trying to get consistency in our definition. Regarding maternal care, 2 terms are critical. Opioid use disorder, or OUD, is the maternal condition placing the infant at risk for developing clinical symptoms, and MAT, or medically assisted therapy, is a combination of pharmacologic and therapeutic interventions for the mother. The newborn terminology has also evolved and has been clarified over the last several years. Opioid-exposed newborn, or OEN, is any infant exposed to opioids at or prior to delivery. Symptoms are not required for use of this term. Neonatal abstinence syndrome, or NAS, was our initial descriptor for symptomatic infants. However, this is now recognized as a generic form referring to clinical withdrawal from any substance exposure, such as cocaine, amphetamines, etc. The new term, NOWS, neonatal opioid withdrawal syndrome, refers specifically to the newborn withdrawing from maternal opioids. What you see on this slide is a critical concept. Infants are not born as addicts, nor are they actually addicted to any drugs. All of these infants are withdrawing from particular substances. In order to provide optimal care for the dyad, again, the mother and infant couplet, avoid the use of judgmental words, some of which are shown on the screen. Each mother has her own unique reason for opioid use disorder. What is the source of maternal opioid use during pregnancy? 14 to 22% of all pregnant women receive an opioid prescription during pregnancy. The major source of opioids for these mothers delivering a symptomatic newborn is prescriptive. Over 65% of the opioid use disorder mothers received a prescription through medically assisted therapy or other legal prescriptions. To review the scope of the problem in Tennessee, look at the following slide. This slide shows the year-to-year number of newborns diagnosed with neonatal opioid withdrawal syndrome, and the slides use the older nomenclature neonatal abstinence syndrome. Of note, the number of cases significantly decreased in the year 2019 compared to previous years. 2020 data is being followed closely as there has been an overall increase in opioid-related problems during the COVID pandemic. It'll be interesting to see if we see any changes in the neonatal abstinence or NOWS rate due to the COVID epidemic. That data just isn't in yet. The geographic distribution of the problem has changed slightly over time as well, with minor improvements noted in the Northeast Tennessee area. However, further spread westward into rural counties has also been noted. You can reference this map to determine the number of reported cases in your county. This slide shows a different way of graphically looking at the regional differences over time, again showing the highest case counts are in Northeast Tennessee, but importantly, improvement has been noted over the last 2 to 3 years. This illustrates the point that change can be effected even in a very high-risk population. The overall Tennessee rate is approximately 10 cases of neonatal abstinence syndrome or NOWS per 1,000 deliveries, which is a decrease from the high of greater than 13 cases per 1,000 deliveries in 2017. So it is possible to move the needle, and we've seen nice improvement, like I said, up through 2019. This slide shows that specific opioid-related problems are not solely noted with the withdrawing newborn. Significant changes in the incidence of other maternal and infant disease processes are also noted. This is not a standalone problem. And look at the myriad of conditions that can affect the infant and the maternal conditions during the pregnancy period. If you look at symptoms of neonatal abstinence syndrome, specific newborn clinical signs of withdrawal are rarely found. They can often be confused with other neonatal conditions such as sepsis, seizure disorders, etc. Think of it as a diagnosis of exclusion. For example, the most recent patient I cared for was born at 35 weeks gestation, had hypoglycemia with tremors, which improved with glucose therapy, but then became irritable and tremulous again at 4 days of age. Maternal opioid use was noted at that point. It had not been detected previously. So again, identical clinical symptoms to a commonly found newborn condition with hypoglycemia, but a very different cause. When do newborn symptoms usually appear? Very rarely symptoms are noted at birth. The onset of symptoms is dependent on the type of substance the infant was exposed to. Also, importantly, each newborn may have a different clinical response to the same maternal opioid use. We recently had 2 mothers, both on 16 milligrams per day of buprenorphine. One infant developed symptoms of withdrawal, the other did not, illustrating again that everyone's response to medications and drugs can be drastically different on the same dose. Another critical thing to talk about is cost to the healthcare system. And the costs of the healthcare system have increased with longer length of stays for pharmacologically treated newborns. Costs have increased due to associated diseases such as hepatitis C, and costs of a supportive social network, DCS, TEIS, the other agencies that support these moms and babies after discharge. The Medicaid population has been disproportionately impacted with a 10-year increase in neonatal abstinence syndrome rates from 2.8 to 14.4 per 1,000 live births. That's a huge increase, and again, illustrating the amount of cost that the state public health system has to be able to compensate for. Newborns covered by the Medicaid program have significantly increased rates of transfer to a higher level of care, increasing costs, and also have a significantly increased length of stay compared to the non-Medicaid population. For example, between 2004 and 2014, the cost of care for these newborns increased from $65.4 million to $462 million. That obviously is a significant expenditure, and it has impacted healthcare budgets and policy decisions affecting not only the moms and babies that are affected, but all Tennessee residents. It's similar to the current COVID crisis where ICU beds are filling up with COVID patients, but you're really going to have to provide care for everyone else in the population who may also need those same type of resources. The cost of care for newborns affected by a neonatal opioid withdrawal system is roughly 5 times the cost of caring for a non-affected newborn. Again, these dollars are being utilized at the expense of other public health needs. Overall, the opioid use disorder, mother and infant, continue to present a lot of challenges to the public health system. As we've shown, this is a moving target for improvement, with regional, cultural, and bias-based confounding factors being noted. The costs to the healthcare system are significant, but we can improve this through a systematic approach to the problem with consistency of care. Now we'll move on to perinatal and other considerations of care for the mother and infant. Thank you.
Thank you, Dr. DeVoe, for getting us started on our talk. My name is Patty Scott. I'm a nurse practitioner here in the Middle Tennessee area, and I'm also the Infant Quality Improvement Specialist for TIPQC. So this brings us to our second key idea, the best practices for prenatal, inpatient, and discharge care. Now, ACOG, the American Congress of OBGYN, recommends universal screening for all pregnant women. This is important so that we can identify these mothers who are opioid dependent so we can offer assistance. It's also important to identify these mothers so we can adequately observe their newborns. Screening example tools for screening could include CRAFT or the 5 Ps. We want to screen, we want brief intervention, and referral to treatment, SBIRT. But screening and testing are not the same thing. Universal testing is not recommended. There are problems with universal drug testing, which include limited detection windows. It may actually overestimate use, and then legal concerns. We need to ensure that we have a plan of care for these pregnant women so we can help them connect with resources during and after their pregnancy. Connections with social work, case management. Case management often is available through their own managed care organization. We want to discuss any barriers to care and help them identify a follow-up care provider for their baby. We want this provider to be someone who is knowledgeable in the care of infants affected by opioid exposure. Now let's discuss the best practices in the hospital. Facilities and caregivers need to have consistent screening policies in place. Remember, it is not necessary to drug test an infant if mom has documented compliance with her medication-assisted therapy. So when do we want to consider testing the newborn? If we have a mom who's not compliant with her treatment program, if she has absent or scant prenatal care, usually defined as entry into care after 22 weeks or fewer than 5 visits, or if the infant is displaying signs of withdrawal. Please also note that many places are no longer factoring in THC use as a measure of compliance. So how do we test infants? First, remember that detection windows and cutoffs will vary depending on the different screenings. First, let's talk about urine. Urine has a short window of detection, but it may be useful if mom has tested positive in triage. Remember that some urine drug screens do not test for buprenorphine, and we all know how hard it is to capture the first urine on a baby, and that's really the specimen that gives us the most accurate information. Second is a cord sample. If your facility has been set up for cord testing, then you have the advantage of still being able to test the newborn if you don't see exposure signs until a couple days after delivery. But please remember, this method may pick up delivery medications. And last, meconium. This has a long detection window, but it's most accurate when we collect as much meconium as possible. Not all tests have the same detection, so it's important to know what your facility offers. Non-pharmacologic care begins at birth, and this is the most important aspect of care that we can provide to this newborn. Observation in the hospital is also key. We need to observe for 3 to 5 days for infants we think have been exposed to short-acting agents, such as hydromorphone, morphine, and oxycodone. 5 to 7 days for long-acting exposures, such as methadone, OxyContin, or fentanyl patches. This recommended duration of observation is per the current AAP guidelines, but remember, we need to keep checking those updates because new recommendations are provided often. If the infant's withdrawal signs are severe, then pharmacologic treatment needs to be considered. But please know that often we're able to avoid pharmacologic treatment when we're providing consistent and comprehensive non-pharmacologic care. So what's included in non-pharmacologic care? It's important to include the caregiver as a primary source of comfort, and hopefully this will be the newborn's mother. Mom is medicine. Rooming in has been shown to decrease the length of stay for these newborns. We also want to provide a quiet environment with low lighting. Swaddling can be helpful, but we need to ensure that we're following safe sleep guidelines. Swings and rockers are considered comfort agents, but they should only be used while in the direct care of a caregiver. They are not designed for sleep. Skin to skin is beneficial for mom and baby, and then of course breastfeeding unless it's contraindicated. When can we encourage breastfeeding? According to the Academy of Breastfeeding Medicine, when mom is compliant with her medication-assisted treatment, she's been sober for more than 90 days, she plans to participate in a recovery program after discharge, and she has received adequate prenatal care and has a negative maternal urine drug screen for illicit drugs. What about breastfeeding while on maintenance therapy? Breastfed newborns will receive some of the mother's medication via the breast milk, but this can help them with their signs of withdrawal. It does not treat the withdrawal, but it can decrease their signs of withdrawal. Remember, these babies may require a higher caloric intake, so the breast milk may need to be fortified. Important that the infant's provider is monitoring the infant's weight, watching for excessive weight loss. Excessive weight loss is defined as more than 3% of weight loss per day or more than 8% total weight loss. Careful discussion is required when there has been illicit drug use within 90 days of delivery. Sobriety is demonstrated only as an inpatient. There's a lack of a support system, or if we're concerned that breastfeeding is only being done to avoid separation, for example, DCS. This is very rare, but needs to be considered. We should discourage breastfeeding when we know there's active use or when there is a positive urine drug screen showing misuse or illicit use noted at delivery, when there's a lack of prenatal care, chronic alcohol use, or no engagement in a treatment program, or if we're concerned relapse will occur within 30 days of delivery. This is an important time to partner with mom's OB to develop a plan of care for monitoring. So let's discuss some practical tips for breastfeeding. Since there's a very low volume of colostrum during the first 1 to 2 days of breastfeeding, this actually gives us a little more time to make an informed decision about breast milk. Mom may pump if her sobriety is recent. If she elects to pump, we need to develop a plan with the OB team for urine drug testing and to ensure mom is in a treatment program. Most local labs will not accept breast milk for testing. So how do we wean the infant from breast milk? First, we can either wean the amount of medication for mom. This must be done carefully since there is a high rate of relapse during the postpartum period. Or we can wean the baby from the breast milk by either allowing the infant to self-wean when they're ready to, or gradually decreasing the volume of express milk with substitution of formula or milk depending on the infant's age. Again, encourage this mom to nurse for at least a year or longer. Please remember that HIV is a contraindication to breastfeeding in the United States and in other developed countries. Hepatitis B and C are not contraindications to breastfeeding unless mom's nipples are cracked or bleeding. Then she may need to pump and dump her milk until those areas heal. When should babies be treated pharmacologically? Every facility needs to have a standardized treatment protocol. This protocol should include keeping the infant comfortable, preventing excessive weight loss, and of course, preventing seizures and/or death. This is an example of a modified Finnegan tool along with a list of the signs of withdrawal. Infants identified as prenatally opioid exposed should be evaluated immediately after birth and then scored every 3 to 4 hours throughout their hospital stay. Now, this scoring should be clustered with feeding times. We never wake a sleeping baby. If the score is 8 or greater, we need to repeat it in 1 hour. Rescoring reduces the risk of overtreating for unrelated fussiness. If the score is less than 8, we want to continue to monitor and continue that non-pharmacologic supportive care. Some facilities are showing great results with using PRN morphine dosing instead of routine dosing. This data is still being developed. So just a few scoring tips. First, always score as a team. Always include the family. Second, excoriation should be new or worsening to be scored. Remember, a diaper rash from diarrhea is not excoriation. And last, breastfed stools are not diarrhea. Look for water rings or large volume watery stools. Now I'm going to introduce Dr. Anna Murad. Dr. Murad is the director of the newborn nursery at Monroe Carroll Jr. Children's Hospital at Vanderbilt, and she's the infant medical director for TIPQC.
Hi, everybody. I'm Anna Murad, and thank you, Patty, for that nice overview. So we have discussed best practices in the hospital setting, but we need to consider what constitutes best practice in discharge. What will set this family up for success? When we look at discharge process, we want to avoid readmissions. This study found that shorter length of hospital stay was associated with an increased risk for readmission. It also found that rates were similar to that of late preterms. So it behooves us to consider how we provide some safeguards around evaluation after discharge. A natural question to ask may be, what about discharging home on medication and having the baby wean off pharmacotherapy at home? This study found that the length of treatment time was extended with outpatient weans, thus exposing the baby to longer exposure for medication. The new AAP guidelines from October 2020 also discourage this practice. Best practices are to discharge a baby when their clinical symptoms are under good control, their weight is stable, their caregiver is confident in providing their care, and they have a solid plan for discharge follow-up. The discharge checklist is an absolute best practice for care for the opioid-exposed baby. Referrals to early intervention services, and remember in Tennessee, that is TEIS, hepatitis C follow-up if mom was positive, developmental follow-up if the baby met criteria for NAS, and remember all babies should have periodic developmental screening in their pediatrician's office with a validated screening tool. Those consist of PEDS, MCHAT, ASQ, for examples. Every baby should have a date and time appointment documented for follow-up with their PCP. A warm handover to the PCP is a good idea if they did not follow the family inpatient. And finally, home support services such as nurse home visiting or CHANT would be a good idea. CHANT is the Community Health Access and Navigation in Tennessee and is available in each of the 95 Tennessee counties in the health departments. It provides 17 pathways of care with services that range from home visiting to employment coaching. Circling back to early intervention, one thing to know is NAS Now's diagnosis is on the automatic eligibility list for TEIS. That list can be found on their website. And opioid exposure was recently added to the list along with these other ICD-10 codes that require secondary MD review to qualify for services. It is important to use the correct ICD-10 code on the referral and include pertinent information in your documentation. The information needed by the secondary MD reviewer is the source of exposure and approximate duration. So you can document mom is compliant on MAT with subtext for the duration of the pregnancy, or you may have something like this. Mom is in treatment or not in treatment, an infant with polysubstance exposure of unknown duration, but most recently with heroin and benzo use in the 3rd trimester. The reviewer knows that we may not be able to pin down all of the details, but they need an overview when they are making decisions about qualifications. Finally, as part of your discharge process, don't forget about mom. It is important that she has a treatment plan, and it's helpful to share local resources with her. Remind her about the Tennessee Breastfeeding Hotline, and she can call for assistance 24/7. This discharge process is very amenable to a QI project for implementation and tracking for sustainment. Let's move on to discuss hepatitis C. What percent of Tennessee newborns with hepatitis C exposure do you think had appropriate follow-up care? Unfortunately, only 23%. It is critical that moms have appropriate screening, and the new CDC recommendation is that every mom should be screened during pregnancy. And certainly moms with substance use disorder require this hepatitis C screening. There's approximately a 4% vertical transmission rate for the baby and a 25% risk of cirrhosis later in life. The new Red Book recommendation allows for earlier testing at 1 to 2 months of age, and of course there is the 18-month testing that is also recommended, but getting the baby into referral sooner can help them to not fall through the cracks for follow-up. Here's a quick look at hepatitis C rates in pregnant women in Tennessee. And you can see that the rate has increased dramatically, mirroring the opioid epidemic. Here's another way to look at it across the country. And then here you can see the state as a whole, and you can see the prevalence is higher in the counties with higher numbers of moms with opioid use disorder and infants with opioid exposure. This is a nice algorithm for screening that was developed by Dr. Jimmy Carlucci, and is a reminder that it is fairly simple, and a primary care provider should be able to provide this service. So let's move on to pediatric care and what we should be doing in our primary care offices. The first thing is to recognize and validate the symptoms that may linger for months. These babies can be harder to care for and require additional consoling techniques. Review the non-pharmacologic measures with families and remind them of the things that were helpful in the hospital setting. Remember that these babies are at increased risk for non-accidental trauma, especially in the setting of stressed caregivers. It is important to review coping mechanisms with the family, such as taking time to regroup, mindful pauses, and other things when the baby is not consoling easily. Also review safe sleep and the importance of sleep positioning. In addition to opioid exposure, these babies often have multiple risk factors for sudden infant death syndrome, such as tobacco exposure, formula feeding, or unsafe sleep practices. Failure to thrive can be an under-recognized issue. The metabolic requirement for these babies can be much larger than you may anticipate. Frequent weight checks and increasing calories, either by introducing supplement after breastfeeding, fortifying expressed breast milk, or using a higher calorie formula can be good ideas. Diarrhea can be a particular problem, and there is some thought that lactose-free diets can sometimes help with that. Frequent weight checks do not necessarily mean frequent trips to the office. These babies often qualify for home health nursing if there's an ongoing weight issue. I mentioned on the discharge checklist the importance of developmental surveillance. Use of a validated developmental screening tool is critical. Tennessee AAP has a training course called START to teach you how to implement formal screening and referrals in your office setting. We, of course, mentioned hepatitis C earlier, but do remember that you can screen as early as 1 month, but more likely with your 2-month well-child visit. Consider HIV screening, especially if you don't have documented 3rd trimester screening for mom. Finally, trauma-informed care. So what does this really mean? It means that we as providers recognize that this family may have trauma, and we need to create a system of respect and trust. It means training your staff on appropriate language to use and how to destigmatize care. Engaging the family as a partner in the care for their baby will ultimately create better outcomes. In conclusion, we're appreciative of your time and hope that you will consider these best practices for the hospital setting, discharge planning, and follow-up care for babies with opioid exposure. Thank you, and please feel free to reach out to TIPQC for more information or additional resources.